This is the 3-question warm-up for Endocrine 4. First question, what patient groups must avoid fluoroquinolones? So we avoid giving fluoroquinolones to children and to pregnant women because of the risk of possible fluoroquinolone-induced joint and cartilage toxicity. Next, how is hnRNA processed before it leaves the nucleus? So you're going to add a 5' cap, you're going to add a poly-A tail, you're also going to splice out the introns. Then after all that's done, you're left with an mRNA that's ready to leave the nucleus. Next, a 4-year-old girl complains of pain in her genitalia. On exam, a discharge is noticed, and a smear of the discharge shows Neisseria gonorrhea. How is she infected? Well, this is an STD, right? So in a child, an STD is going to be a sign of abuse. So this is childhood sexual abuse. All right, let's move on to the lecture.
In this video, we're going to focus on glucocorticoids like cortisol and what happens when you have too much cortisol, which is Cushing syndrome. So let's start with cortisol. Cortisol is very important. It has effects on lots of different systems, and you need to be familiar with the various actions of cortisol. So first of all, cortisol is a stress hormone. Our bodies release cortisol in response to stress, and if you remember that, it can help you remember a lot of cortisol's effects. So cortisol helps to maintain the blood pressure by upregulating alpha-1 receptors in your arterioles. In Pharm Basics, you heard about alpha-1 receptors and how they cause vasoconstriction. But cortisol is not directly stimulating the receptor itself, it's upregulating the receptors. So it causes vascular cells to put more alpha-1 receptors on the cell surface, and overall that makes the vasculature more responsive to epinephrine and norepinephrine. And without that upregulation, the patient may have a hard time maintaining blood pressure. This is clinically useful if you have a patient with septic shock and they're hypotensive, they're not responding well to IV fluids and pressors. It might be because they have a relative cortisol deficiency. So by giving cortisol or another glucocorticoid, you can help raise the blood pressure. Also, in times of stress, you need to have plenty of energy substrate around, so cortisol will increase gluconeogenesis, it will increase lipolysis, and also proteolysis. So with all these mechanisms increasing blood sugar, some people won't be able to process that, and the high cortisol or steroid use over long periods of time can cause diabetes. Cortisol also has anti-inflammatory effects. It suppresses the immune system and suppresses inflammation. So this can be good in small amounts, but it can be bad in large quantities and over time. Interestingly, even though cortisol suppresses the immune system, when you first put a patient on glucocorticoids, their white blood cell count will rise. So on your rotations, if you have a patient with like a COPD exacerbation and pneumonia, and the white blood cell count is elevated and you give them prednisone, then the next day you see the white count is more elevated, don't assume they have some new infection or are getting worse. What's really going on is the glucocorticoids have stimulated movement of the white blood cells out into the blood, and it's temporary. Cortisol also decreases bone formation, which is why people with high cortisol from Cushing syndrome or from taking glucocorticoids such as prednisone for too long can get osteoporosis. But before we talk about the possible pathological effects of cortisol excess, let's talk about the usual regulation of cortisol. So the hypothalamus secretes CRH, which is corticotropin-releasing hormone. CRH stimulates the pituitary to secrete ACTH, adrenocorticotropic hormone, and ACTH stimulates cortisol production in the adrenal zona fasciculata. Then also, cortisol provides negative feedback, so it decreases both CRH and ACTH. We see this kind of negative feedback loop throughout the endocrine systems. And we can see here that there are 3 different ways to interrupt production of cortisol. So if you knock out the adrenals, that's primary cortisol deficiency or primary adrenal insufficiency. If you knock out ACTH production at the level of the pituitary, that's 1 step away from the adrenals, so that's secondary adrenal insufficiency. And if you knock out CRH production in the hypothalamus, that's tertiary adrenal insufficiency, which is interesting semantically but not really clinically. So we're going to talk about adrenal insufficiency in the next video. Now let's talk about the various glucocorticoids. So these are synthetic glucocorticoids that are used as medications for a huge variety of indications. Usually when we say we're putting a patient on steroids, we're talking about glucocorticoids and not the kind people buy from a shady dealer at the gym. So there's hydrocortisone, which is essentially chemically identical to cortisol. Then there's prednisone, which probably is the most commonly used glucocorticoid. There are prednisolone and methylprednisolone, commonly used in IV form, which is called Solumedrol. There's dexamethasone, which in addition to the usual pharmaceutical uses is different because it isn't measured on the cortisol blood test. And we'll talk about that again with Cushing syndrome. There are many preparations of topical steroids like triamcinolone or hydrocortisone, which we use for rashes and all kinds of mild to serious skin inflammation. Then there are inhaled glucocorticoids like beclomethasone and triamcinolone and fluticasone, used to treat inflammation in the bronchi and the lungs. There are steroid nasal sprays, which are used for allergic rhinitis and nasal polyps and so on. And there are lots and lots more of these. And most of them end in "-one", but not all of them. And mineralocorticoids like aldosterone also end in "-one", so be careful. The mechanism of action of these drugs is the same as cortisol, but again, we're mainly using these for their anti-inflammatory effects, so in terms of the mechanism of reducing inflammation, they reduce cyclooxygenase and phospholipase A2, so you have fewer pro-inflammatory mediators like leukotrienes and prostaglandins. As for side effects, chronic glucocorticoid use is by far the #1 cause of Cushing syndrome, and I'm sure you're familiar with the basic features of Cushing syndrome. There's redistribution of fat, which causes truncal obesity, and a buffalo hump on the back of the neck, and a big round moon face. There's muscle wasting, thin skin, easy bruising, and while we're talking about skin things, you should also remember that Cushing syndrome can cause purplish abdominal striae and also acne. And then we talked about how cortisol raises blood sugar and can lead to diabetes. So these other glucocorticoids can do the same thing if you take them long enough. And then we mentioned that cortisol inhibits bone formation, so you can see osteoporosis as an adverse effect. Steroids can cause an increased risk of glaucoma and also peptic ulcers, and then they can cause some neuropsychiatric issues like insomnia and psychosis or agitation. And then steroids also cause tertiary adrenal insufficiency due to the negative feedback and subsequent atrophy of the adrenal cortex. So again, we're going to cover adrenal insufficiency in the lecture on adrenal pathology, so file that away for right now. All right, to regroup, here's a mnemonic for those signs and symptoms of Cushing syndrome. BAM Cushingoid, to stand for buffalo hump, amenorrhea, moon faces. The C is for crazy, to help us remember the psychosis and agitation that some patients get. The U is for ulcer, as in peptic ulcer. The S is for skin changes like acne, striae, thinning of the skin, and easy bruising. Then there's hypertension, infection, necrosis of the femoral head. The G stands for glaucoma and cataracts, which are both eye problems. Then osteoporosis, immunosuppression, and diabetes. Learn this list. You definitely need to know every single item on this list. They might ask, which of the following side effects can be attributed to prednisone, for example? And you'll give a list of side effects, and you need to know every side effect. That might be helpful for you. All right, so let's talk about Cushing syndrome in more detail. So Cushing syndrome is a syndrome of elevated cortisol, which can be due to a variety of different causes, and there are lots of things that can cause Cushing syndrome. So we already mentioned that the #1 cause of Cushing syndrome is iatrogenic, from exogenous glucocorticoid therapy. So when you take a lot of glucocorticoids, especially high doses or for a long period of time, that steroid provides negative feedback to the hypothalamus, decreases CRH and ACTH production. So remember that, that's going to be important in a minute. Then besides exogenous steroids, you can also have endogenous causes of Cushing syndrome, and these come from several sources in the body. So a common cause of Cushing syndrome is Cushing disease, which specifically is due to a pituitary adenoma, not a prolactin-producing tumor, but a pituitary tumor that produces ACTH. So obviously in these patients, ACTH will be elevated, and the ACTH stimulates the adrenals to produce cortisol. You can also have a non-pituitary tumor or a cancer that produces ectopic ACTH. Small cell lung cancer is the classic cause of this. And again, in this situation, ACTH will be high. Then a fourth cause of Cushing syndrome would be that one of the adrenal glands just produces too much cortisol, like from an adrenal tumor, an adenoma, or even from a carcinoma. Now, most adrenal adenomas are completely benign and non-functional, so they don't produce any hormones at all, but occasionally they will produce cortisol. And here you'll have negative feedback to the pituitary and the hypothalamus, so ACTH is going to be very low. It's going to be essentially undetectable because the adrenals aren't responding to ACTH stimulation, they're just producing cortisol on their own. Now, one clarification I want to make about the frequency of the different causes of Cushing syndrome. Traditionally, Cushing disease, an ACTH-secreting pituitary adenoma, is considered the second most common cause of Cushing syndrome behind the iatrogenic causes. In fact, this is what it says in most Step 1 review books. However, other sources suggest that ectopic ACTH syndrome from small cell lung cancer may be more common than Cushing disease, but probably is underdiagnosed. Now, I can't imagine you're going to get a question that explicitly asks you, what is the number 2 cause of Cushing syndrome? But I think the point is that you need to be able to recognize which things are common and which things are rare, so that clinically you can pick out the most likely diagnosis and not start chasing the exotic rare stuff. So let's talk about the dexamethasone suppression test, which is a test we use to differentiate between these different causes of Cushing syndrome, and then we'll be finished. So to perform a dexamethasone suppression test, you give the patient a low dose of the synthetic glucocorticoid dexamethasone, and then the next morning you check the cortisol level. We always use dexamethasone for this test instead of the other glucocorticoids because it's the only one that doesn't interfere with the cortisol assay. So you can interfere with a point in the hormone cascade without interfering with the measurements. And there are a lot of ways to do dexamethasone tests, but I like to think of just 2, a low dose 1 milligram test and a high dose 8 milligrams over several doses. So in a healthy patient, if you give a low dose of dexamethasone, it will decrease production of ACTH from the pituitary, that feedback loop, and then in turn will decrease cortisol production at the adrenal level. So when you check the cortisol level the next day, the cortisol should be suppressed. That's why we call it a dexamethasone suppression test. If you have a patient with a pituitary tumor that's producing ACTH, the cortisol level will remain elevated following a low dose of dexamethasone. But if you then give a high dose of dexamethasone, you can sort of break through that resistance and you can suppress ACTH, and then cortisol will be suppressed. So it's suppressible, but only with a high dose dexamethasone. Then with an ectopic ACTH-producing tumor, such as a small cell lung cancer, you still have elevated ACTH, so cortisol won't be suppressible here either. But it doesn't matter if you give low dose or high dose, the cortisol will not suppress. Cortisol is already high from the tumor and remains high after both low-dose dexamethasone and high-dose dexamethasone. So maybe now you're wondering why high-dose dexamethasone suppresses pituitary ACTH production, but not ectopic ACTH production. And the way I think about it is this. So in a lung cancer that's producing ectopic ACTH, that tumor is lung tissue. It's not pituitary. It's not supposed to be producing ACTH. So no matter how much dexamethasone you give, that lung cancer just won't respond to the normal feedback inhibition by glucocorticoids. But if you have a pituitary tumor, if you give a high enough dose of dexamethasone, you can make it remember that it's pituitary tissue, and it will start responding to the negative feedback from high doses of dexamethasone. But tissues like the small cell lung cancer just don't have that feedback inhibition mechanism built in. Then finally, if you have Cushing syndrome from a cortisol-producing adrenal tumor, the dexamethasone suppression test will look just like the results from an ectopic ACTH-producing tumor. The adrenals aren't responding to ACTH in the first place, so ACTH from the totally normal pituitary is already suppressed by the high cortisol level. So if you give dexamethasone, cortisol will remain high, whether it's low-dose or high-dose dexamethasone. So the only tumor that's suppressible is the ACTH-producing pituitary tumor, and that's only with high-dose dexamethasone, not low-dose dexamethasone. So if the ectopic ACTH-producing tumor and the cortisol-producing tumor look basically identical on your dexamethasone suppression test, how would you tell them apart? Well, think about that for a minute. So you can check an ACTH level, right? What's that going to show? Well, the patient with an adrenal tumor, a cortisol-producing tumor, will have low levels of ACTH because of the negative feedback. And a patient with a small cell lung cancer that's producing ectopic ACTH will have high ACTH. Okay, so before we wrap up, let me mention one more related condition, which is called Nelson syndrome. Nelson syndrome occurs in a patient who had persistent Cushing disease from a pituitary adenoma. Usually the clinical scenario is the patient had pituitary resection and the disease persisted despite this and possibly other medical interventions, and eventually the patient has bilateral adrenalectomy to treat the hypercortisolism. Then in response to the lack of adrenal feedback, over time the patient can develop progression of the pituitary tumor even if it seemed gone before. So of course this doesn't cause hypercortisolism again because the adrenal glands are gone, but it can grow and cause compressive symptoms or even pituitary apoplexy. Okay, so that's it for the glucocorticoids and Cushing syndrome. So I know this is a little confusing, especially the dexamethasone test, but it's really testable stuff, so make sure you're comfortable with it. Now it's time for the end of session quiz. So pause the video and answer the quiz, then we'll go through the answers together. First question. An adult man with elevated serum cortisol levels and signs of Cushing syndrome undergoes a dexamethasone suppression test. 1 milligram of dexamethasone does not decrease cortisol levels, but 8 milligrams does. What is the diagnosis? So his cortisol suppresses with high-dose dexamethasone, but not with low-dose dex, so this is probably an ACTH-producing pituitary tumor. This is Cushing disease, a pituitary tumor that produces ACTH. Next, what effect does cortisol have on bone formation and immune system function? Cortisol decreases both. So cortisol reduces bone formation, which can lead to osteoporosis, and it also suppresses the immune system, which is why patients on chronic steroids are at risk for infections. The immune system is suppressed. What are all the potential side effects of glucocorticoid use? So make sure you know each and every one of these. As I said, this is at least a 4-star topic in and of itself. Iatrogenic Cushing syndrome. This will cause Cushingoid features like moon facies, buffalo hump, muscle wasting, truncal obesity, thin skin, and easy bruisability. You can also see insomnia, psychosis, glaucoma, acne, osteoporosis, peptic ulcers, and glucose intolerance or diabetes. And you can come back to that mnemonic BAM Cushingoid as well. All right, that's the end of the quiz. But we have one rapid fire fact to go over, and it's the most common cause of Cushing syndrome. Number 1, by far, exogenous corticosteroid use. Number 2, probably ectopic ACTH secretion, which often goes unrecognized, as we said, which makes number 3, or maybe another number 2, an ACTH secreting pituitary adenoma, which again is Cushing disease. And number 4 would be an adrenal tumor that secretes cortisol, because those are pretty rare. That's it for our lecture on glucocorticoids and Cushing syndrome. In the next video, we'll finish up the adrenals.
Doc, ever since my wife got Cushing syndrome, I just can't seem to look at her the same way.
What do you mean? Is it the weight gain?
Not really.
The buffalo hump?
No.
Muscle wasting?
Uh-uh.
Abdominal stria, easy bruising, truncal obesity?
Nope, nope, and nope.
Oh, of course, hirsutism.
Actually, it's kind of a turn-on.
Okay, I give up. What exactly is the problem?
Every time I look at her big, round moon face, I kind of turn into a werewolf.
Really?
See what I mean?
Well, at least now the hirsutism theme makes more sense.